Dear audience, thank you for joining me today. I'm going to talk about my field of research, the role of advanced hemodynamic monitoring in critically ill patients. First of all, here is a short overview of my first research. Mortality of critically ill patients in shock reaches 60%. Therefore, hemodynamic monitoring of these patients would have a crucial importance. Therefore, evidence regarding its outcome benefits is still lacking. Our systematic review and meta-analysis showed that with the use of advanced hemodynamic monitoring devices, the odds of mortality in the hospital can be significantly reduced in shock versus conventional hemodynamic monitoring. This way, advanced hemodynamic monitoring should be recommended in shock patients. Further randomized trials and large-scale registries should focus on identifying the shock phenotype that benefits the most, and guidelines should be updated in light of our findings. I'm Liliána Nagy. I'm a sixth-year medical student and an MD PhD student here. I have a vision of keeping critically ill patients in highest safety, and I would like to achieve the same by using accurate monitoring for accurate condition assessment. I started 2 projects about advanced hemodynamic monitoring, one in the ICU and one during anesthesia. Both would be systematic reviews and meta-analysis. In my first project, I'm investigating the efficacy and safety of advanced versus conventional hemodynamic monitoring in patients with shock. The problem is that shock affects 10% of hospitalized patients, and out of 10 affected people, 3 to 6 die depending on the type of the shock. The main cause of death in the acute phase is the hemodynamic instability, yet protocols regarding hemodynamic monitoring are lacking evidence. We know that conventional monitoring is widespread but inaccurate during the centralization of the circulation. This way, cardiac output monitoring would have a pathophysiological rationale, but it's invasive, cumbersome, and expensive. We are still missing the outcome benefits of cardiac output monitoring, so I aim to evaluate it in shock. Let me show the available methods. Within advanced hemodynamic monitoring devices, we distinguish 3 subgroups. The more complex and accurate devices operate on the principle of thermodilution, the pulmonary arterial catheter, the PICO, and the LITCO device. We involve only these devices in this study. There are also non-calibrated devices that are less invasive, and they only estimate cardiac output. And theoretically, ultrasound works as well, but it doesn't really have a clinical relevance as a continuous monitoring method. I have a clinical question: whether therapy guided by cardiac output monitoring is a safe and more efficient alternative to conventional one in shock patients. Using the PICO framework, my hypothesis is that the therapy guided by cardiac output measurement significantly improves shock outcomes. We conducted a systematic search on 3 databases in November, and we got more than 12,000 results at the beginning, and ended up with 36 articles to analyze. The outcomes are measured in odds ratios with 95% of confidence intervals, and also weighted mean differences. We finished the analysis about mortality, length of stay, the need for different types of organ support, its length, and also the received fluid amounts. I would show the results about the in-hospital mortality, which is the number of deaths from admission until discharge from the hospital. In this case, the outcome is measured in odds ratio. If it's higher than 1, it means that the patients in the advanced monitoring group are more likely to die. Here we analyzed 20 studies about more than 400,000 patients. And in our case, the heterogeneity is high, but it's something we expect due to pooling 2 devices, different shock and study types together. In our case, the odds ratio is 0.65, so with the advanced hemodynamic monitoring, patients are 35% less likely to die, which is a huge result in improving survival. The confidence intervals are also on one side, which means our results are statistically significant too. In this manner, advanced hemodynamic monitoring should be chosen for unstable patients. I would also show the results about the number of patients requiring different types of organ support, where we measured the need for different types of organ support, such as inotropic and vasopressor support that reflects best the hemodynamic instability, and also the need for mechanical ventilation and non-invasive ventilation, renal replacement therapy, and mechanical circulatory support. In this case, we analyzed the data about more than 600,000 patients, and subgroups were made according to shock and study type. And here, looking at the overall odds ratios, we can see that patients in the advanced monitoring group are more likely to require all of these organ support. This means that these patients were in more critical or more ill condition, but despite that, they still had a better chance to survive. So advanced hemodynamic monitoring should be part of managing shock paper. I'm happy to share that this study might be the most comprehensive one on the topic so far, presenting a definitive answer to highly important clinical questions. Our results can be implemented to clinical practice immediately. We face some limitations as well, like there is limited data about other types of shock and the LITCO device, and we also had insufficient data to meta-analyze the organ dysfunction scores. I have a conclusion. When the therapy is guided by advanced hemodynamic monitoring, the odds of mortality is significantly reduced in the hospital. So I have an implication for practice supporting the early use of advanced hemodynamic monitoring devices in shock, and further research should focus on defining the shock phenotype that would benefit the most from this device, and developing more accurate, less invasive devices as well. Talking about the progress of my first project, I'm ready to plan my manuscript now. I would continue with my second project, where I'm investigating the efficacy and safety of cardiac output and derived parameters guided therapy in high-risk surgical patients. The problem is that high-risk surgical patients represent only 10% of overall cases, but they are responsible for about more than 80% of all perioperative deaths. In this population, oxygen delivery is of major importance, so we can agree that monitoring cardiac output would have high relevance, yet only 1 in 10 patients receive this. We know that conventional monitoring works well in low-risk surgeries, but they are inaccurate in high-risk ones. So these non-calibrated devices would be minimally invasive, simple to use, and real-time. And we are still missing its outcome benefits, so I aim to evaluate it on post-operative outcomes. I would show once again the available methods. Here, thermodilution using devices are not suitable since they are very invasive and expensive to use them only for a couple of hours. So in this study, we involved the non-calibrated devices with the FlowTrack and PulseoFlex. These devices need only an arterial line, and there's just a sensor attached to it, so it's proper for monitoring during anesthesia. Here my clinical question is if therapy guided by non-calibrated hemodynamic monitoring is a safe and more efficient alternative to conventional one in high-risk surgical patients. Using the PICO framework, my hypothesis and expected clinical implication is when therapy is guided by non-calibrated hemodynamic monitoring, its postoperative outcomes can be significantly improved. Currently, I'm in a preliminary search stage using a search key on Frey databases, and I already got thousands of results. Here, the key articles I found so far fit into the framework of my research. And I think both of my projects seem to be achievable, and I plan to finish them, the first one this year and the second one next year. And I would close my presentation with a quote to keep our patients in highest safety. Do to others as you would have them do to you. Thank you for your attention.
In your first project, when you were showing the mortality forest plot, I noticed that all articles were moderate or high risk according to the risk of bias analysis. What was the problem in these articles?
Yeah, thank you for asking this. Actually, it was about that mainly I had observational studies to analyze, and when we were doing the risk of bias assessment, then there was a domain that reflected on did the patients get this intervention because they were in a more severe condition, and that's our case. So for that domain, we had to add that, yes, the patients received this intervention because they were in more severe condition, and it was not randomized, of course. So that was the main reason behind that. And actually, because of this, it already reduced the risk of bias was elevated.
I would like to ask regarding your second project, because this is issue that I also encountered by the definition of what is a high-risk patient, what is a high-risk surgical patient, based on your point of view, I mean with the critical care point of view, and if you could shed some light, how would you choose that population?
Yeah, sure, thank you for your question. So we can divide the high-risk definition to 2 points, like if the patient is high risk, do they have more comorbidities, are they really old, are they, so do they have higher chance to die during the operation, because the definition of high-risk surgery means that the patient has more than 5% to die during or after the surgery. And we can also consider that the type of the surgery is also very risky, like when there is an aortic aneurysm surgery, or there is a transplantation surgery with really life-taking organs. So yeah, those cases really take this into high risk.
Do you think that LITCO and PICO has different roles in monitoring, or you can use either?
Well, actually, thank you for the question. They are a bit different, because LITCO uses lithium and PICO uses just cold water. So they are quite different. But what I have seen in clinical practice was only the LITCO, the PICO device, and what we could only involve to the analysis was also about the PICO device. So we could not find any kind of literature about the LITCO device, sadly. So that remains a question, that what kind of effect it has on mortality.